Bismillah ar-Rahman ar-Rahim. This is a lecture that I did for Pakistan Society of Neurology annual meeting in 2021. And it's the topic for our talk today, how to approach genetic neuromuscular disorders. This is something what I deal with on a regular basis. And I can understand that many neurophysicians and even regular doctors find it difficult to handle genetic testing and how to handle these patients. This is a slide of galactic constellations, and unless it's a trained eye, I can totally understand that it is very hard to pick a pattern. And there are more than 88 different constellations. And it is kind of similar when it comes to genes. So unless your eyes and brain are trained to look at the particular mutation, it really becomes difficult to understand that is that genetic mutation is what causing the disease or not. I will start with my case, who was a 36-year-old female who was previously diagnosed myositis. And then 5 years ago, she noticed difficulty in walking with the right leg limping. She has difficulty from getting up from the floor for past 2 to 3 years. She felt breathlessness on going upstairs and difficulty in going downstairs. There was no difficulty in raising arms above head, or in other words, there was no upper extremity involvement. There was no family history of similar disease, but 2 of her sisters have some retinal abnormality. Her workup, which was presented to me at the time of clinic visit, showed that she had previous history of hypothyroidism, which was being treated. These were the additional labs she brought in with, and her aldolase was noted to be high significantly in the past, as well as CPK, which was in thousands. So for general physicians, if the CPK is more than 1,000, it means there is something going on with this patient and it needs further evaluation. Additionally, her anti-SSA antibody and anti-SCL antibodies were positive. Probably that was the reason this patient was diagnosed with myositis, but her disease has been slowly progressive over the time. On examination, most of her neuroexam was normal, except there was mild difficulty in getting up from the floor on squatting, and there was questionable golf hypertrophy. She had a nerve conduction study done in the past, but I had a chance to repeat the study, and there was electrodiagnostic evidence of degeneration changes in lower extremities as well as lumbar paraspinal regions. There was no electrodecremental response on repetitive stimulation in 2 muscles, and I felt these changes were consistent with more diffuse muscular dystrophy or myopathy or metabolic disorder. So my assessment for this patient was that she had probable limb girdle muscular dystrophy, which was at this time predominantly involving the lower extremity. And my reason for that was that it was slowly progressive over the past many years. And despite her CPK and aldolase was high, the inflammatory markers, including ESR, C-reactive protein, were normal. I discussed the pros and cons of genetic testing with her, and we proceeded with the genetic testing, which I'm going to present during my talk. So there are different approaches in the genetic testing. So there is a targeted approach where you kind of focus on a particular gene and try to look around it and try to diagnose the patient. With this particular approach, if the genetic disorder is not picked up, there is a possibility there may be genetic mutations outside that target, which may be missed. The other approach is other end of the approach is broad approach. In broad approach, naturally, there are possibility of picking up abnormalities or genetic mutations which may not be playing part in patients' physical manifestation. So each approach has its own pros and cons. The other thing or terminology which we come across in genetic disorder is phenotypic pleiotrope. It means that there are many different phenotypes for mutations in one gene. So it may be many different manifestations of a mutation in a mutation of the single gene. The other part of that is the genetic heterogeneity, which means that there are many different genotypic or gene involvement giving the same phenotype, just making it more complex. So one gene giving you many different phenotypes and many genes giving you similar phenotypic manifestation. So as doctors and geneticists start picking up genetic abnormality, the easiest way was to find a particular phenotype and correlate it to the genotype. And that was called phenotype-genotype correlation, which was easy. But with the passage of time, what they noticed, or the researchers noticed, that there are particular loci related to particular genetic mutation. In other words, there may be one loci or one gene involvement and giving you many different phenotypes. And at that time, it was called as linkage error. And as you can see from the example of Park 1, Park 2, Park 3, there was Parkinsonian features or manifestations with many different genes, gene 1, gene 2, gene 3 involvement. With the passage of time, it just became more complex. And then there was genomic nucleotide sequence with associated features included in the nomenclature or when we documented genetic mutations. But it was just getting complex over the period of time. And there were patients who were having intermediate manifestation or phenotypic presentation, and the genetic mutations make it more complex. So these patients were called as phenotypic spectrum. So they were not having the full spectrum of the disease, or maybe the milder variant, or somewhat different manifestation beside the typical manifestations. So they were included in the phenotypic spectrum of the disease. And then there was a molecular approach when there was karyotype to single nucleotide or methylation changes, which were picked up by different genetic testing. And that's what I call the galaxy of stars, or in other words, it's a conundrum of different genes. This is the photographic explanation of what I was just telling. So the easiest way was the genotype-phenotype correlation, and the classical example was the trisomy 21 giving you Down syndrome. When it comes to genetic heterogeneity associated with the phenotype, it's many different genotypes giving you same phenotype. The example is CA-CNA1A, SCN1A, ATP1A2, and PRRT2 giving you hemiplegic migraine. On the other end, the phenotypic Theotropy associated with the genotype, where the one gene giving you many different phenotypes. Beside part 1 we discussed, the ATPA1A giving you and alternating hemiplegia, rapid onset dystonia, or infantile epilepsy could be one of many examples. So for broad approach, what's included in that is chromosomal microarray. We also call it CMA, or exome sequencing, or whole exome sequencing, or whole genome sequencing. So exome sequencing is what we routinely do when we are not really clear. The genomic sequencing at this point is mainly confined to the researchers. But as a physician or a neuromuscular subspecialist, what I do is the panels. So what happens in a panel is there are a particular set of genes. It could range from tens to hundreds. And those are tested as part of one panel. When we look for any particular panel related to the phenotype, there are different laboratories offering different panels, and it can guide us about picking up abnormality. Again, we have to pick up the phenotype and look for the particular panel in the genetic laboratory. So the different approaches could be based on the genomic variation. So there could be chromosomal aneuploidy, which means there is chromosomal structural abnormality. It could be monosomy or trisomy. And the best way to pick up the abnormality is karyotyping. And the other way to detect is chromosomal microarray. But if it's a balanced chromosomal karyotyping or translocation, karyotyping is the best tested, and chromosomal microarray not gonna pick it up because it's a balanced mutation. If it's an unbalanced mutation, then chromosomal microarray would become the best test of choice, and karyotyping can be done to see the chromosomal structural rearrangement in which the loss or gain of genetic mutation occurs. If there's a chromosomal copy number variation, depending on the size, if it's a size of more than 5 megabase, karyotyping can be done to detect the abnormality, but the chromosomal microarray is more sensitive because it can pick up an abnormality of 100 kb and more. Chromosomal micromethylation is another way of testing the abnormality, especially for silencing of the genes. It's the addition of the methyl group to cytosine, which is called imprinting. And unless we do methylation sensitive analysis, this abnormality is not going to be picked. Then if we go further down in the genetic testing, there is more sensitive or at the smaller level testing, which means the genetic and the exome level deletions and duplications. For the deletion and duplication of the entire gene or of a specific exon within a gene. And the best test for that is multiplex ligation dependent probe amplification, or MLPA. And FISH can be done as well in these cases. But as I said, it's just becoming more complex and complex with the passage of time. So if it's the same sequence of DNA motifs being repeated, or it's called a short tandem repeat, the best test is Southern blot rather than the sequencing testing, because they're going to be missed on the sequencing. And these are the most commonly seen in patients with movement disorder cases, like Friedreich's ataxia. For the single nucleotide variant, as we were just discussing, if there is any change in the nucleoside sequence, it could be insertion or deletion, the sequencing analysis would be the best choice. For single gene sequencing, there are many strengths and weaknesses to every way we do it, but it could be cheap if we are targeted, but if we keep on adding more genes, it actually becomes more expensive. For the gene panel sequencing, what we routinely do in the neuromuscular division, it could be cheap, and also it checks a big bunch of chromosomal or genetic abnormality, which could be helpful in these patients. But compared to the single gene analysis, gene panel sequencing in individual testing could be expensive. Then comes the exome sequencing. And actually, by this method, we check almost 20,000 genes simultaneously, making it more efficient. But there is possibility of picking up a lot of variants of unknown significance, and it is naturally way more expensive. And as we discussed, the genome sequencing is mainly reserved for the research setting. So that would be the one way to kind of approach the genetic disorders. The reasons for the genetic testing could be many. So it may help us in deciding the medical management strategies of the patient. There could be targeted medical therapies like nusinersen for spinal muscular atrophy. And there are more and more targeted therapies coming into the market, like for Duchenne muscular dystrophy. These patients can be enrolled in the clinical trials, which could be helpful to promote research. Also, we can predict the chances of recurrence, especially when it comes to myotonia or other neuromuscular disorders. We can predict that what are the chances of recurrence of the disease or manifestations in this patient, like in porphyria. We can also do the reproductive counseling. What are the chances of transmission? And I think that is something our patients really like to know. What are the chances the next generation going to be involved? Also, the care can be directed to more physiotherapy if there is no treatment available, or to targeted medical therapies. So that could be really helpful. Also, these patients can be part of the support group, which can help us in developing a kind of group of people who share experiences together. Next, there are certain dilemmas of genetic testing, as we already discussed, especially when we do the whole exome sequencing. There could be incidental findings. And the important thing is what we're going to explain to the patient. Do we really need to explain it to the patients? What are the abnormalities? Are those abnormalities making sense to us? Especially if it's going to make sense to me, then I will explain it to the patient. And it also saves the patient from unnecessary medical management, especially when it comes to patients who receive steroids or immunosuppressant therapy by many physicians, which could be detrimental for their health. We can also organize the appropriate investigation, which will save the cost or the burden of the testing on the patients and reduce the healthcare cost. But this is very important to go step by step when we approach these patients or any problem in neurological disorders. It could be multi-specialty referral for these patients, which is very well needed, because these patients need not only neurophysician, they also need geneticists, they do need cardiologist, ophthalmologist, or orthopedic doctor to promote quality of care. So my approach in a patient with a genetic disorder, especially when it comes to the neuromuscular disorder, is to get a really detailed history, starting with the age of onset, the progression of the disease, the involvement of the pattern of involvement of the patients, with the emphasis on the family pedigree and the childhood details. The examination, the documentation are the key component to document how things are progressing and to make it more reasonable in the future that this is the pattern of the involvement in my patients. The complete workup could be based on the region of neuroaxis involvement. It could be nerve-based investigations, neuromuscular-based, or the muscle-based. Again, it all comes from the history, examination, and initial investigation where you're going to put your money on. So then you can do the electrophysiological testing, which clarifies more what part of the neuroaxial region is involved. I can sometimes do it before blood workup to kind of decide the area of involvement. Then I proceed with the genetic testing. And again, based on the case, I will decide what particular panel I have to do, or do I really need to do for the whole exome sequencing, which I rarely do in my clinical practice. And also in even rare cases, I proceed with the biopsy. So when it comes to the genetic peripheral polyneuropathy, again, I go by history, detailed examination, family pedigree, and the inheritance pattern. So I also write down in my assessment, what do I feel based on the history and examination? Is it an autosomal recessive or autosomal dominant disorder, or it could be mitochondrial, because the history is going to give you a better idea rather than you just jump to the testing. And then if it's a neuropathy, then I will proceed with the neuropathy screen labs first, which includes a hemoglobin A1C, the tier 1, tier 2, tier 3 investigations, and the nerve conduction study to see what kind of neuropathy it is. And then I may proceed based on if it's a demyelinating polyneuropathy, then I may go just for the PMP22 testing, either deletion or duplication, and it can be reflex to extended panel. But if it's an axonal, then you can just go to the extended panel for the CMT assessment. But also you need to remember there are other disorders, including metabolic disorder, Raxums, leukodystrophies, where there could be peripheral neuropathy, and that will not be part of the CMT. So we need to be careful when we do our assessment of the patients. And the nerve biopsy can be done rarely in selective cases. In case of neuromuscular junction disorders, again, after taking a detailed history and examination and the family pedigree, I rule out metabolic disorders and acquired ones like acetylcholine receptor antibodies. Nerve conduction study, electromyography can be done. And then additionally, repetitive nerve stimulation should be done to look for the neuromuscular junction defect. Also, then I proceed with genetic testing for congenital myasthenic disorder, which can be reflex to the whole neuromuscular panel in case you are not getting clear from the initial investigations. In case of the muscle disorder, also following the same scheme, I try to look for the metabolic or the acquired disorders, always look at them first because they may be more treatable compared to the genetic disorders, which at this time, the cost of the therapy is pretty high. Then I proceed with the nerve conduction electromyography and the genetic testing, looking for, is it a dystrophy, myopathy, or channelopathy? And in some cases, it can be reflex to complete neuromuscular panel. And rarely we can do muscle biopsy, especially if it's a metabolic disorder, to kind of see what kind of metabolic disorder it is, or it's a mini-core myopathy or disorders of the same sort. So if you look at the way I approach, the history and examination has the prime importance, followed by investigations and then genetic testing and rarely biopsies. It may seem simple, but again, it really takes training and organization of your approach so you can save time, you can save money for the patient. So the teamwork is the key for me. When a neurophysician or neuromuscular subspecialist evaluates a patient, you also need a clinical geneticist on the panel to discuss your case and what kind of particular panel we can offer and which lab to test for. Because it's not only the knowledge of the history and examination and what you are suspecting, but also you need to know the itsy-bitsy details of what particular lab is offering that particular panel, which is inclusive of what you're thinking. So there's a lot of depth to that. And then you need to do the pre-test and post-test counseling because there may be results which may not be significant, or at the other end, there may be many psychological or social consequences of the testing. And then if you do have the liberty of having a neurometabolic specialist, it could be really helpful. They are really rare. and clinical geneticists are very rare as well, even in developed countries. So having those on board actually makes it much more easier job for you to complete and really label a patient with a definite diagnosis. The same goes for the pediatric neurologist, because they do see metabolic disorders way more than a regular neuromuscular subspecialist. Again, histopathologist, if it comes to the biopsy, and especially if someone who is trained in neurohistopathology, could be really helpful, but they are also very rare commodity to have. And then you need a bioinformatics specialist to put all the data in the system for the genes and kind of look for a particular abnormality for you. And the support services, as we already discussed, physiotherapy, speech therapy, occupational therapy, orthotics, orthopedic surgeons, cardiologists, ophthalmologists. So it just takes a big team to kind of develop an approach where you are more cost effective and efficiently get to the diagnosis and help your patient in totality. I also worked with the undiagnosed disease network. What does that mean is that a patient who has been undiagnosed, despite the fact you have tried your best, and then at some point in future, you go back and look at the data and try to find out if there are any missing links or any missing piece of information which can be gathered again and which can be helpful for diagnosing your patient. Again, I personally, working in Pakistan, even with the limited resources, found it very helpful. So I will say it takes a village to raise a child, and it takes a whole team to provide a quality care to one patient. So in my case, what I came up with was a variant of unknown significance. And two of those people who don't understand that, so there could be variants of, there could be a genetic abnormality, which is giving you, put your patient at risk. So those are the risk variants. Then there are variants who give pathology or manifest as a pathology. Those are the pathogenic variants. And then there are variants of unknown significance, where there is not enough data, and with the passage of time, it will become more clear. So these are where you have to correlate again the genotype and the phenotype and look at the whole data to kind of see, does it really make sense, and what particular mutation makes sense in particular case that you are looking at. So my patient, despite the fact she had mild weakness in the lower extremity, which was mainly proximal, had agri mutation, which is seen in congenital myasthenic syndrome. So this patient didn't have evidence of pre and post-synaptic neuromuscular junction defect on rep stem. The other mutation was CACNA1S, which is seen in malignant hyperthermia, hypokalemic periodic paralysis. This patient never had an episode of hypokalemia or periodic paralysis in the past. And then there was PLEC mutation, which is seen in limb girdle muscular dystrophy, autosomal recessive 17. So I felt that this may be significant in my case, despite the fact it's a variant of unknown significance, but it to some extent fits with my case. For the SINEN 1, it's Emery-Dreifuss muscular dystrophy type 4, and also it's also seen in spinocerebellar ataxia, autosomal recessive type 8. So again, there was no contractures in my patient. So every details matter when it comes to the history and examination and when you get to the genetic point. So this patient already had muscle biopsy when she came to me, and there was scanty tissue with residual atrophic fibers and fat replacement. And there was concern for muscular dystrophy other than dysphalinopathy. The second review also showed there was no significant change in fiber size. So to my understanding, if you will just look at this data, at least there was no evidence of inflammatory changes in this patient. So my impression was that this patient had limb girdle muscular dystrophy or myopathy, secondary to probably unknown genetic mutation with no evidence of neuromuscular junction defect or inflammation. I still need to rule out autoimmune overlay, despite it seems mainly genetic limb girdle muscular dystrophy. So there was abnormal laboratory testing, but it may not manifest in the muscle. We all know that. So I presented my abstract in Asian Oceanic Conference of Neurology in 2021, where we presented 43 patients, and out of those 43 genetic testing, 30 patients were included in the study. The demographic details were collected, including the duration of the symptoms and the medications tried in the past. And if you notice, almost 50% of these patients were tried on steroids, which means that they actually didn't need that treatment, and it could have been more detrimental in their case and delayed the care. And the number of physicians they consulted before coming to me was approximately on average 5.3. So the satisfaction with the neuromuscular services out of the 30 was 24, and it was also documented. So out of these, 15 patients have confirmed genetic mutations, and almost 50% have variants of unknown significance or negative mutation. So in summary, genetic testing is the standard of care for genetic neurological disorders. Large but common events are non-pathogenic. Large but rare events are usually pathogenic. It's expensive and results could be confusing, as we discussed. The teamwork can save time and money for the patients. Avoid treatment, especially steroids and immunosuppressant therapy, without confirmed diagnosis. If somebody want to take 1 point from this presentation, that would be it. Because they are not dying, they are not an emergency. We really need to work it out before we start these high-end medications, because it could be more detrimental to our patients. It provides specific and accurate diagnosis in selective cases, which is really helpful, and it actually boosts patient satisfaction and also satisfaction of the clinician that they are contributing to the society. So these are a couple of useful resources. I use Gene Review quite frequently. It has a whole lot of detail on particular genetic mutation, and also for the phenotype. It also gives you a detail pertaining to particular neurological disorder. OMIM is another which I use very frequently to kind of correlate the genetic mutation in my cases and go through the variants of unknown significance. There are multiple others that you can check for. Also, the Concert Genetics is a website. You can kind of register with that, and it gives you the idea of what particular labs in US or in other countries offer what particular panels and what are the costs to that. Also, the Face2Gene is one app where you can correlate different facial features, and it gives you what could be the possible genetic mutation. I rarely use it, but naturally, if you're doing a dedicated genetic clinic, it could be helpful. Also, we recently started our YouTube channel for education of the patients about different genetic disorders and to educate the masses. So I would like to pay my acknowledgement to Dr. Jun Lee, who is the current chair of neurology in Wayne State University. And he was my main mentor when I was doing CMT clinic at Vanderbilt. Dr. Brian Burnett, who was a muscular dystrophy consultant and associate professor and a neuromuscular subspecialist in pediatrics. And he really helped me learn, especially when it comes to the pediatric neuromuscular disorders. Dr. Sarah Khan, she is a current professor at Aga Khan University and helped me look at these slides. And also she is very helpful for me during my course in Pakistan. Dr. Maria Sarfraz, who helped me with organizing the data. I still get to my genetics teams at Vanderbilt because the resources are really scarce in Pakistan, and it becomes really difficult for me to kind of look at all the pieces, and they have been very helpful for me. Thank you very much, everyone.